some more people trickle in. Hello, and welcome to Putting the Eggshell Plaintiff Back Together Again, treating accident victims with pre-existing conditions, sponsored by us here at Injury Institute and the San Diego Injury Network. From your friends at Injury Institute, we are always there for you as a medical lean network that connects the best medical providers to our personal injury patients. We are co-sponsoring this webinar with our sister organization, the San Diego Injury Network, who represents the Injury Institute in San Diego. So a big thank you to Jennifer Evans-Wong, as always, for helping put together this fantastic webinar with us. We have a full panel for you today who are going to go in depth on how best to handle cases for clients with pre-existing conditions. To begin our panelist introduction, we have our wonderful BB Fell from Fell Law. BB primarily practices in the areas of catastrophic personal injury and wrongful death. BB is a member of the American Board of Trial Advocates, and she has been selected to be a member of the National Trial Lawyers Top 100 Trial Lawyers, the Daily Journal's Top 100 Women Lawyers, and Super Lawyers. And of course, we have Michelle M. West. She's a partner with Robinson Calcagny. She has devoted her practice to obtaining a recovery for catastrophic injury and wrongful death cases. She is a top 50 female super lawyer and a SoCal super lawyer. She's a proud board member of the Los Angeles Trial Lawyers Charities, Western Trial Lawyers, and a proud marathoner. She has completed over 10 Ironmans and almost 100 marathons, as well as the Badwater 135-mile race. Then, to introduce the doctors on our panel, we have Dr. Hassan Badai with Pacific Pain and Regenerative Medicine in downtown LA and Irvine. He is a double board certified, fellowship trained interventional pain management specialist and stem cell surgeon. Next, there's Dr. Kurosh Kolahi with Pacific Spine and Orthopedics, an orthopedic surgeon with additional advanced subspecialization in the hand and upper extremity. His expertise focuses on bone and soft tissue disorders related to trauma, sports injuries, overuse, arthritis, and age-related degeneration. Last but never least, we have Dr. Eric Korsch from San Diego Spine Center. And Dr. Korsch practices as a spine surgeon and treats injuries to the cervical, thoracic, and lumbar regions of the spine. His surgical expertise includes minimally invasive spinal procedures, disc replacement surgery, and anterior posterior fusions. And with that, I will defer to BB and Michelle to introduce our topic for today.
Okay, so we're here to talk about the Eggshell Plaintiff today, which for any of you who do personal injury work, should be a topic that's near and dear to your heart. It's one of the first questions we ask in intake. Have you had any problems with that particular area before? And it's one of the last questions that the jury will consider on the jury verdict form. So literally from the very beginning of the case to the very end of the case, whether your client qualifies as an eggshell plaintiff or might have pre-existing conditions is front and center to the analysis of the value of your case and the value of your client's injuries. So, Michelle?
Oh, well, you know, I am prepared a little something to share, so just bear with me while I just talk a little bit about your eggshell plaintiff. I'm just going to try to breeze through this because this is something we deal with in every case. The eggshell plaintiff, like, look, everybody it seems like all of us have pre-existing injuries, right? Millions of people have pre-existing injuries. If you've lived at all, you've suffered. In 2019, there were 4.4 million car crash victims who were injured seriously enough to seek medical attention. That's a statistic from the National Safety Council. And it's all ages of people who are going to have past illnesses and injuries. The Centers for Disease Control statistics show that 325,000 children are treated for sports-related concussions in our country. And you can get these statistics if they're helpful for you in explaining pre-existing injuries to your jury. One in every 4 workers experience low back pain. So that means 40 million American workers have back pain. So when your potential case comes to you and you ask about, okay, well, I understand you're in a car crash and you have back pain now, but did you have back pain before? And the client tells you, well, yeah, I just had a car crash 2 years ago and I had a surgery after that case. You know, what you don't want to do is you don't want to refuse the case simply because there was pre-existing complaint of pain, illness, or even past surgical intervention. What you do want to do is immediately get those medical records, MRIs, and films and review it so that you can see what the history was for your client. Of course, we all know, and it's valuable to look at the jury instruction 3928, you must decide. The jury's going to hear, you must decide the full amount of money that will reasonably and fairly compensate the plaintiff for all damages caused by the wrongful conduct of defendant, even if the plaintiff was more susceptible than a normally healthy person would have been. So it's valuable to look at that sometimes, to remember. And a plaintiff without such a pre-existing condition would probably have suffered less injury or no injury. It does not exonerate a defendant from liability. You always remember from law school, the tortfeasor, the defendant, takes the plaintiff as they find them. So what do you want to do with these pre-existing conditions? You don't want to hide from them. You don't want to hide them. You want to embrace them, and you want to accept it, and you want to explain it to the jury. The defendants want to use them to avoid paying for the harm that they've done and to avoid their responsibility. So you need to understand the past and be able to differentiate the effects of this particular accident and the injuries suffered from the past injuries and conditions. You'll use your experts to assist you in doing that. One thing I like to do is I like to explain the work that was done by your client to get to the place where they had been right before this incident. So if they had a past car crash and they had a surgery, you need to explain what happened, where they treated, how often they treated, what the complaints of pain were like, and show the hard work that they put in to get into the position that they were in before this current collision or accident that they have been involved in. You want to use calendars to show that your plaintiff, worked every day. They got their surgery. They did their rehab. They showed up at their PT sessions every day. They took their medication, and you want to be able to put a timeline together to show the jury all the work that they did and how the pain complaints lessened, how the treatment lessened or even stopped, and they were doing well until this new incident that you're going to provide help for. You want to do is pour over the medical records and avoid surprises. Do not just rely on the client's word. Often they don't remember if they've been injured, or they'll say, oh, I've never had any problems before now. You want to make sure you review all the records, look at all the imaging available to you so that you understand and you can help your client get ready for deposition and trial. You want to immediately work with your qualified medical experts, like the ones that we're going to hear from today, so you understand the differences between the past injury and pain complaints, or understand the similarities and how it has exacerbated the injury or condition or illness that they had before. Remember, it's a defense to your damages, not a defense to liability. So concede it and use it in a credible and ethical way. And use the experts to dissect the damages being claimed from this incident versus the pre-existing injuries, and ask only for that percentage of the injury or damages that are attributable to this new incident and not a penny more. Don't be greedy, be honest. The jury will appreciate that. This is very important today, and I'm sure our panelists are going to show us how to do this. The jury wants to see it. Don't just tell me that you didn't have pain before and you were done with treatment. Show me. We want to see the films. We want to see the past injuries, and you want to work with your experts to do that. Make sure the client understands that the problem with the pre-existing injuries and how you're going to deal with it. Show the trajectory that your client was on to the jury. Was your client getting better and they continued to get better and improve? Or had they already gotten better and they were doing well, they had plateaued until this incident happened? Explain to the jury using that timeline and using their treatment from the past. Also, you want to show the length of time between the past incident and the past complaints and the new incident. You want to talk to family members about what they were able to do before this incident. You want to talk to treaters and coworkers. How were they living their life before this incident, a new incident, even with their pre-existing conditions, and how they are dealing with it now. And I also think as trial lawyers, we want to tell a compelling story. So a compelling story I heard is Alex Smith, the Washington Redskins quarterback who suffered a break in his tibia and fibula. He had 17 surgeries, had infections, and almost lost his leg. But he rehabbed, he survived, and he came back. He wanted to play in the NFL again. 2 years later, he, with the support and love of his family and his team, he was able to return to the NFL. So I know we're not, representing NFL players likely, but we represent the heroes of our story, and we want to show that our plaintiffs are the heroes of their story. Okay, so they've had illnesses and injuries in the past, and we want to show how they dealt with those, how they live their life. So make your client's story as compelling as Alex Smith's story, and that's what I would say. Just tell the story of your clients and how they dealt with their past illnesses or pre-existing injuries.
So I'll add a little bit to what Michelle said, and then we'll turn it over to our doctors who can walk us through some things from the medical perspective that can help us in our cases. But, I think I like the rule of threes. It sounds really well. So I have a rule of three when it comes to pre-existing conditions. I think the three things that you want to focus on when you're looking at a case with pre-existing conditions is number one, normalize it. Number two, embrace it. Number three, disregard it. And so I'll give some examples of those later on throughout the talk, but normalize it means if you've lived life, like Michelle says, you've got pre-existing conditions. So we want our jurors to think that our plaintiff is just like every single one of them. If you have lived to be of a certain age, you are going to have degeneration in your spine, in your joints. And so we want to make sure that our experts are talking about what age that is and what percentage of the population it is. And even though that percentage of the population has degeneration, they're not experiencing pain. So number two, embrace it. There are some situations where we have a smaller amount of forces, a smaller car accident, for example, and it might be difficult to explain how it is your client got injured when they were hit at such a low speed. Well, the pre-existing conditions can explain that. So embrace it, because in the right case, you'll only win it because there's pre-existing stuff. And then lastly, disregard it, because it's not about the condition, it's about life. It's about your client's life experience. And we can't know what our client lost until we understand what our client had. So you want to do a really good comparison of what their life was like, what activities they were engaging in before the accident versus how their life has dramatically changed after. So I think with that, we're going to turn first to I believe it's Dr. Kalahi. Are you going first?
It's Dr. Badai with pain management perspective.
Oh, okay, great.
So
Dr.
go ahead, Dr. Badai.
Well, listen, thank you for having me on. And I will say that I think that's a fantastic rule of three. And I definitely will back that up to my full acknowledgement, because the rule of three really is, when we're talking about pre-existing pain, let me put up my slide deck, but this rule of three is really important. And I do think that it is part of our normal population. I mean, I do pain management in my offices here in Irvine and downtown Los Angeles. And I can tell you maybe, 2/3 of my patients have a pre-existing pain in the spine, whether it's the lower back and neck, just because it is normal part of living, aging. Everybody has, some kind of musculoskeletal ailment of some sort. But the question is like, okay, well, did this particular event that led us to this personal injury circumstance, did that cause or exacerbate a condition that was previously resulted in some pain symptoms and that was previously stable? So that's a key information piece, right? So I'm just going to skip to a one slide deck that I tell jurors when I'm, presenting as an expert. I do present, and this is a common question that comes up, and I paint this scenario to my jurors or to my patients, and I tell them, like, look, guys, imagine you or the patient is that stick figure on the right, and let's say that there is a boulder at the top of that hill or that mountain. You have no idea how long that boulder's been there. You have no idea if that has been there for months, or if that's been there for years, 10,000 years in this circumstance, or in a lifetime. But something caused that boulder to come crashing down, whether it would be in, like a small rainstorm or a big earthquake. In our personal injury perspective, whether it be a small 5-10 mile an hour bumper to bumper collision or a high velocity impact. And that boulder then started that landslide of pain. And that's really what it is. It's a landslide of pain. Now, how did we know if we didn't have any pre-existing MRIs or any issues? Those are things that we typically will find on the first presentation, will be the first one to order MRIs. If patients traditionally come in and say, I've had, conservative treatment, chiropractic treatment, physical therapy in the past, and I've had x-rays, but really soft tissue degenerative displacements were never noted until this presentation was in front of me. So we'll order those diagnostics and then we'll see that. But really, it's important to kind of discuss what we see, and what we have to determine is a very careful history, right? So, and it is very part of any good medical history intake form should have a question. Hey, have you ever had pain or injury in these areas before this particular event? Yes or no? And we typically would have a patient explain that in our intake form as an example. Then the follow-up question to that would be, hey, did these pre-existing pains, did it get better as previously to this event? And did it completely resolve prior to this impact or this event? And then what was the pain level in the weeks or months prior to this new injury? So, all of this data is super critical in terms of determining with our physical examination. And as physiatry trained, we tend to spend a lot of time with the physical exam and trying to determine a complete neurological assessment. But we can determine with a reasonable degree of medical certainty, given the history, given the physical exam, given the imaging findings, if there is one or previously, if this event was exacerbated, the condition that was previously resulted in pain symptoms, but was stable and was responsive to prior, treatment. So those are things that, we see quite often, but it's not anything more than understanding that this is quite normal. We should embrace it. And yes, I would disregard previous injuries to be as like, oh, well, this is a component of this new injury. So did this person's pain level prior to the injury, well, let's say here's the level, let's see if you guys can see my hands, but if it's like here, the event occurred here, and now their new baseline level of pain is here, did that essentially change someone's activities of daily living? Did that in turn change someone's quality of life? So we have a very careful approach in the physiatry pain management world that we have to address those things that are contributing to those quality of life changes, right? Can Mr. Johnson pick up their grandkids anymore when they used to prior to the injury? Could they sit in a car for long periods of time? Can they work? Can they drive? Can they self-care? Can they tie their shoelaces without pain? Can they, have marital relations? Can they, so all of these factors are really important in determining, did this event cause a level of pain to be worsened? If that's the case, in my practice, in my medical practice, we treat, and I treat with full vigor about what I need to do to get that patient back to previous baseline levels. And that's really kind of an important aspect. Now, I have other slides, but I just really want my audience to really understand a pre-existing pain. The one slide or the one thing that people need to know is that there is a boulder at the top. You don't know how long it's been there, and a little fender bender caused that boulder to come crashing down. And that could be something like that. Or a high velocity impact can cause that boulder to come crashing down. It doesn't matter. If they were stable and now they have worsening inflammatory pain, soft tissue conditions or spine conditions, that's essentially how I would render services or render care based off of maybe a personal injury visit.
May I just ask Dr. Badai, you said that about 2/3 of the patients you see have pre-existing conditions. How do you ascertain that from them? Is it direct or is it through the uncovery process of your
it's essentially a very specific questionnaire, and it's a very specific direct question. Now, it's part of my protocol. I just say, okay, Ms. Johnson, did you have lower back pain prior to this event? And I go through that. I love that rule of three. I'm going to embrace it. I'm going to tell them it's quite normal to have it. I want you to know it's very, common. And they will tell me, they say, well, I've had some lower back pain because I sit on the desk all day long, and, I have neck pain, but it is significantly worse. Well, how much worse, and they would tell me, well, I can't play tennis. I can't tie my shoes. I can't pick up my grandkids, that sort of thing. I can't work. So, and it's quite common. I mean, the population I see are, just like I think I saw a slide. I mean, anywhere from any age bracket. I have minors who I do focus on care, as well as patients who walk through my door who are 92, 93 as an example today.
Great. And we actually had a question that just came in saying that, I know you do stem cell injections.
Yeah.
How is it that, what percentage of defendants you get pushback because it's seen as experimental treatment?
Good question. So I have an entire protocol that I would render before I get to these very advanced new levels. But what we're seeing today, and I could speak for hours on this, so I know I'm very limited on my ability to speak on this, but what I will tell you is that what we had seen 10, 20 years ago is now being more and more accepted. I probably, if everyone's in front of me, I would ask to see how many hands would go up if they're saying, oh, PRP is now part of standard of care. I'm sure the majority of the people who are listening would say, yes, I've heard of PRP. Well, as of about 8 weeks ago, we are now involved with a Q code that allows for amniotic treatments, amniotic fluid treatments, which is a form of regenerative stem cell care, to get reimbursed by the Centers of Medicare and Medicaid. Not a lot of people know this. And this is as of this summer that we are now seeing reimbursements from Medicare for regenerative amniotic fluid treatments. And if people are interested in this information, please direct message me or things like that. But stem cells is also something that is considered investigational experimental, although I've been using it in my practice for the last, I say 10 years, since I've been an early adopter to this, because, hey, can I get my patients better without complex surgeries? Can I get my patients better without opiates? Can I get patients better without, steroid-based treatments? And again, the idea is all about the ADLs and the QOLs, or the quality of life, right? Can I get that patient to do what they were doing prior to the event or the accident or the injury? And so stem cells I do use, but there are PRP treatments, amniotic fluids that are well documented and accepted, and everyone will be hearing about the use of amniotic fluid as part of their protocol, because it is now, as of in the last 8 weeks, been very accepted as a Q code that is available to us as providers. And even my surgeons who are on the panel, I would love to talk to them about it. But yeah, so regenerative.
It's interesting. It's interesting to hear that has been standardized now. So that's wonderful.
Yeah, I mean, as my practice, like, this is maybe last July is when we started our first treatment to see reimbursements.
Wonderful.
That's pretty cool.
And with that, I would love to go over to Dr. Kalahi with the orthopedic perspective.
All right, well, thank you very much for having me. Let me see if I can share the screen.
So let me stop sharing here. Okay.
All right, yeah, so I'm Dr. Kalahi. I'm an orthopedic surgeon, and my subspecialty is hand, wrist, and elbow. So today with the limited time. I thought it might be good to go over some of the most common injuries I see in my subspecialty, which is hand, wrist, and elbow. And then next, just go over a couple injuries which are a little bit, can sometimes be a little bit more difficult to explain, through an accident. We can go through those. And then just for fun, a couple of recent cases that might be interesting. More higher injury stuff though, not eggshell. So for me, the most common eggshell injury that I see is arthritis at the base of the thumb, which here on the left, you can see kind of a moderate arthritis at the base of the thumb, and on the right is, more advanced. This is, just like arthritis anywhere, but especially common for the hand, where a patient may not even really have any symptoms until there's some sort of minor trauma or even major trauma, like an accident or a fall. And then all of a sudden the, pain is awakened, and, we do what we can to try to calm it down, but it becomes an ongoing issue from there. But from the x-ray that it was obviously something brewing there beforehand. And, a lot of the hand injuries are dependent on the position of the hand at the time of injury. And this is the most common for when, someone exacerbates arthritis at the base of the thumb. And kind of easy to explain how this would exacerbate the pain at the joint in that area. And, basically for arthritis, when you lose cartilage in a joint and it becomes, more painful over time, there are kind of two categories of ways to deal with it. There's basically pain management, because there's no way of replacing the cartilage at this time, or there's surgery. Pain management is, basically supportive care, wearing a brace as needed, anti-inflammatories, or trying injections can be helpful, but it's known that, those injections are going to be a temporary thing, because there's no curing arthritis in that sense. But when it gets to a point where it's, pretty debilitating, you can consider surgery, and there's different ways to do it, but the main concept is, removing the arthritic joint and putting your own soft tissue in between, and generally pretty successful, but it's, it's like a last resort for this type of thing. You try to avoid doing it for as long as possible. The next most common thing that I see is carpal tunnel syndrome. And typically, right here is on the left is showing a diagram. This yellow structure here is the median nerve. And that nerve runs straight up the middle of the wrist into the hand. And typically from, a steering wheel impacting that area directly, you do commonly see people with mild carpal tunnel syndrome beforehand having it more frequent, or even what we call acute carpal tunnel syndrome from a really high impact directly to the nerve, where they may not even had carpal tunnel syndrome before, but a direct impact can, really make that come to light. And typically for this, patients will have numbness in this picture, kind of the yellow part of the hand, and they may wake up at night with numbness and tingling. They may feel numbness and tingling whenever they're driving. First thing that, we do for carpal tunnel syndrome is wear a brace, something like this, but only at nighttime. And that just kind of gives the nerve a break at night from your wrist hyperflexing. Steroid injections can be helpful, though sometimes they're temporary. And the carpal tunnel release is a option to relieve the pressure on the nerve. Anytime I do a carpal tunnel release, I always order a nerve test. So it's common that someone with carpal tunnel syndrome will get a nerve test before we move on to steroid injection or a release. And, there's two ways to do a carpal tunnel release. One is, a mini open, the other one is endoscopic, and they both work pretty well. But the idea is you're releasing a thick ligament that's right on top of the nerve, and by releasing it, you're opening up the space for the nerve to essentially, breathe, because nerves are pretty sensitive and don't like to have pressure on them. Trigger finger is, I would say, the third most common eggshell injury I see. And basically what trigger finger is, you can see kind of in this diagram, these white ropes are the tendons that, you know, flex the fingers, but they pass through a series of pulleys that we call sheaths. And in this area, in this part of the palm, it's very common for the tendon to become irritated and inflamed to the point where it's not really fitting in its sheath very well. And typically that's kind of from a direct impact to that part of the palm from the steering wheel. And patients will maybe have mild trigger finger beforehand, but it's really severe after an accident. Or I have seen it where, you know, acute trauma can cause a trigger finger as well. And similar to, you know, most orthopedic things, the treatments are pretty similar. Supportive care is just pretty much stretching for trigger finger. Steroid injections is typically the first step, and if the injections are not helping, you could do a release where you release the pulley on top of the tendon to free it up. That's a picture of that there. The next category is kind of, you know, possible eggshell. I've definitely seen it where in this, you know, case I'm talking about tennis elbow or lateral epicondylitis, where someone's having pain to the outside part of the elbow. Definitely seen cases where someone really is worse with their tennis elbow after an accident, but not as easy to explain as the, you know, first three that I mentioned. So it really just depends on the situation, taking a really good history and exam to be able to understand how much the accident really affected that. And the other one that, you know, is, you know, I put as questionable eggshell is cubital tunnel syndrome, which is similar to carpal tunnel syndrome, but involves a different nerve that comes on the inside of the elbow, which is, you know, the funny bone nerve, the ulnar nerve. I have had cases where from, you know, a side of the car, someone will have a direct impact to the nerve and it's clearly related to the accident, but this one can sometimes be a little hard to explain as well. And then these are just some pictures of a cubital tunnel release. If it comes to that point where someone needs a release, which is kind of the last step. And there's a picture of the, not just a release of the nerve, but a transposition where it has to be moved under a sheet of muscle. And then for the next part, I thought it might be interesting just to go through some recent cases that are more just to kind of see what, you know, these high energy accidents can do to the human body. But if anyone's squeamish, maybe don't look. Is it okay to go through these or?
Oh my goodness. I suppose, yeah. Yes, it's very informational. Oh.
This is just for, you know, just for fun in a way. This is a patient who kind of lost some tissue to his fingers and really wanted to try to preserve the fingers, especially since in the ring finger, he also already had a previous tip amputation. So he really wanted to do everything we could to save it. And then for this, what you can do is what we call a cross finger flap, where you just borrow tissue from another finger and then put skin graft where you borrowed it from. And then, you know, over time, that kind of skin takes, and then you can, you know, save the finger. And of course, we see, you know, high energy fractures all the time from car accidents. And typically with those highly displaced ones, you know, different kinds of fixation to restore the function of the wrist. Here's one where a patient lost the thumb pad, which if there's one piece of real estate to the hand, which is most important, it's the thumb pad. So kind of the strategy for replacing that is to take a section of skin here, but you leave an artery attached to it, and then you kind of tunnel that tissue back up this way to replace that pad. And then you can put skin graft over that area. And here's this guy just a few days ago. He came in, it's looking good. And then here's just a similar one, just so you can see what it looks like. This was like from 3 months ago. This is him, a different guy, but doesn't really look that beautiful to most people, but to me that looks pretty beautiful. And then of course, you can have really severe injuries, which you can't really save everything, but you can save whatever you can to give someone some function, and it's better than nothing. That's it.
Well, thank you, Dr. Kalahi. And of course, we want to finish off with Dr. Eric Korsch, who will give the spinal perspective for us today.
Thank you very much. I'm about to put my PowerPoint up. Give me 1 second. And appreciate you having me. I wanted to just real quick touch on what Dr. Badai had said about stem cells not being, or the question was whether they're FDA approved. Real quick, the FDA approves devices and materials. They don't really regulate the use. And if there's a off-label use, it's considered fine for the doctor to use any material he wants in an off-label use. In fact, the FDA does actually regulate PRP and stem cells. So there's no authorization or not authorized by the FDA. It's a misconception that the insurance companies throw at us in order to try and prevent payment. That being said, my talk is actually on spinal surgery and conditions related to the eggshell patient. I put some slides in the beginning that are more legal, and I think BB and Michelle can probably address a lot of this better than I can. I did learn a new word a couple days ago, tortfeasors. I had no idea what that was. Michelle and BB are laughing now, thinking the guys, but I mean, we don't learn terms like that in medical school. When I researched this a little bit, I realized that I've been doing this for years. I've been doing work comp and a personal injury for 23 years in California. I'm a spinal surgeon. Everybody comes with what they come with. Most of the people I see in workers' compensation I've been treating for 23 years have a pre-existing underlying condition. Most of the people I see in motor vehicle accidents have a pre-existing underlying condition. Unless you're a 25-year-old with no history of anything, you're coming in with no pathology. Anybody else is going to come in with some sort of spinal pathology. I just have some definitions about Eggshell Plaintiff Doctrine. I'm assuming this is mostly attorneys on this seminar. I know there's chiropractors and physicians as well, but I know this is a CLE thing. So I'm assuming it's mostly attorneys. I don't want to bore you with any of this stuff. This is simple stuff that you all know. Michelle and BB will go over how to take it and run with it as they already have. But these are just simple things that I found. I've been doing this for years. The Eggshell Plaintiff, you take them as you find them. If there's an aggravation or exacerbation of an underlying condition, that's on the tortfeasor. Everybody is physically and mentally a product of his or her life experience. It's just the way it is. Nobody's coming in clean to any of these things. And again, I don't want to bore you with any of the legal terms. I'm going to show you a lot of the cases I've worked on, and I think that'll be probably more interest. I think when you're talking to your expert or the expert on the other side, it's a simple question for them. Do you have any idea to a reasonable degree of medical probability, this is a sample, when that disc osteophyte at C5-6 would have been symptomatic if the accident had not occurred? Or lumbar spine or degeneration, any of that? The answer is the same. No one could possibly know. It's speculation. I've been using that term in work comp. We have to do a thing where you have to apportion what percentage was pre-existing and what percentage was due to the injury in question. It's pure speculation. Do you have an aggravation or an exacerbation? They're two different things anyway, aggravation and exacerbation. I don't need to go into that. But what they both do is show that there's an actual increase in the symptoms the patient would normally be experiencing. There is no way you can say whether the symptoms would ever occur or when they would occur without speculation. Nobody could say that. Your physician can't say it. The defense physician can't say it. If they do, it's completely inappropriate. When the second simple question, I started this with one simple question, but I came up with the second one. Do you agree that someone could have that problem in the spine and be completely asymptomatic? There's only one answer for that. Of course, it's certainly possible that she could have been completely asymptomatic and may never, ever have had any symptoms at all from this. There's no other right answer. It's impossible because none of us could possibly know. I'm going to start with just showing some of my slides. This is where a pre-existing, this is a patient who was involved in a motor vehicle accident. They had low back pain 6 months previously. 6 months prior to the injury, this is the MRI. There's some degenerative changes. This is a simple one. They came in, had some degenerative changes, a little bit of low back pain. Their physician recommended an MRI. You got some mild degenerative stuff with some disc space narrowing at L5S1. 2 months after the motor vehicle accident, a repeat MRI was performed due to excruciating lower extremity pain. You can see on the bottom here that there is a huge disc herniation that occurred subsequent to the motor vehicle accident. It's clean cut. There's no question about this. Why are you sure the symptoms started at the time of the accident? Well, they had some back pain prior, didn't have any leg pain. After the motor vehicle, they developed excruciating leg pain. The MRI shows a brand new disc herniation. Very clean cut. No one's going to have any problem with this except a defense expert. Man, you can kill them on this because it's clear cut. This is the before picture on the left, the after picture on the right, clear as day. So in the past 23 years that I've been dealing with stuff in the both personal injury and California work comp, it's exactly the same situation. They have underlying issues. This is not rocket science. All you have to do is explain to the jury, explain to the other side that, yeah, they had some symptoms and this is new symptoms. Your new symptoms have been caused by your tortfeasor. The physician's job, I can do this all day long, just not screw it up for you. Just explain this as simply as possible, that we have no idea if they ever would have become symptomatic or if they were symptomatic before, whether they've gotten to this degree of symptoms or pathology absent the injury. These are clear cases. These are patients with pre-existing pathology, degenerative, developmental, or congenital, that I've operated on, and the attorneys have successfully recovered on these cases with clear pre-existing pathology. No one's arguing that they didn't have it. This is a lumbar spine. This is a grade 1 spondylolisthesis. There's a clear step off here. There's a spondylolysis. Clearly, all this is pre-existing. None of this occurred from the motor vehicle accident in question. You can see an old, long-standing degenerative disc, lost hydration. I did surgery, L5S1 fusion on this patient. Pain usually goes away immediately. They wake up with no low back pain. They'll have a little bit of belly pain where we go in through the front, but the back pain's resolved. And the back pain occurred because of this condition. 6% of the population has an underlying pre-existing spondylolisthesis. 6% of the NFL population has a pre-existing underlying spondylolisthesis. But if it's not symptomatic and it was rendered symptomatic by the accident, it's easy to show, and it's easy to prove that the accident caused the symptoms that necessitated the need for surgery. This is clear long-standing degenerative spondy in the cervical spine. There's straightening here, which could be an acute event as well due to muscle spasms, but you can see there's narrowing here, there's narrowing here, there's narrowing here, there's spurring, there's osteophytes, there's disc space narrowing. These are all long-standing pre-existing conditions. She had relatively asymptomatic findings prior. She had occasional aches and pains in her neck, nothing severe. Following the accident, she developed excruciating cervical spine pain with radiculopathy, and she developed neurologic symptoms. She had underwent a 3-level fusion. She did fantastic after the fusion, and they were able to show that the proximate cause of the need for surgery was a motor vehicle accident she was involved in. This is longstanding degenerative disc disease. Right here, you can see what's called discogenic sclerosis. It's a secondary change in the end plate around the vertebral body, showing it's a longstanding degeneration. The disc space is narrowed here. There's a disc herniation in the back. There's a high intensity zone. Usually that's this little white thing. That usually occurs with longstanding degenerative changes. Clear-cut longstanding degenerative changes rendered symptomatic by the motor vehicle accident. Underwent an L5S1 fusion, pretty much a complete resolution of the symptoms within the first 3 weeks after the surgery. I restored the disc space height, took this disc away that was causing neural compression, and the patient had resolution of his symptoms, and the attorney was able to settle. You have to have the radiologist in lockstep. They have to be able to read these things correctly. This is clearly a disc herniation in the back. You can see that there's pushing out of the posterior longitudinal ligament, and that could be from an osteophyte. There is osteophyte in the front. There's a little bit of long-standing changes here. The radiologist read it as a disc osteophyte complex or an osteophyte. Patient underwent surgery with complete resolution of the symptoms. The patient recovered. The radiologist read this as a disc osteophyte complex. Same thing. You can see that there's clear extrusion of disc material posterior to the posterior longitudinal ligament. There's loss of hydration, but there's loss of hydration here. The pathology was here with radicular findings down the leg. Patient underwent same thing, an L5S1 instrumented anterior fusion. The symptoms resolved. They had a pre-existing condition rendered symptomatic by the motor vehicle accident. They underwent appropriate treatment with resolution of the symptoms, no brainer. They can't refute you on the fact that their symptoms started prior. And the symptoms started after the accident and were resolved by the appropriate treatment. Now, what I can't handle, and this is more for my colleagues out in my Riverside practice, I can all day long handle radiologists saying it's a disc osteophyte complex, and deposition and trial. It doesn't matter. It's compression of the exiting nerve root. What did they sometimes say? And this is because, and I just threw this in because it's my pet peeve. When they say there's no soft tissue edema to suggest ligament sprain, tendon strain, or reactive facet joint synovitis, they're just screwing up any soft tissue case you have. So just saying, if someone reporting this, you might want to find a different radiologist. Off topic, I know my pet peeve. I figured I had an audience that can hear me whine a little bit. What you're here for is, when is the need for spinal surgery related to a traumatic event? And what we go with, and it's very simple, when there are new symptoms present after an event, or when there's an aggravation of an underlying pre-existing condition after an event. This is true even if the consequences of the injury are more serious than they would have been had the injured person been in perfect health. We don't see people in perfect health. No one's going to see people in perfect health. So we get the patient as we see them. A minor accident could have catastrophic consequences on patients with the eggshell spine. I'm going to show you one of my most recent examples, and I'm not sure I am time-wise, but this is an actual patient who was involved in a motor vehicle accident in January of 2000, 20 years ago, required an anterior spinal fusion with cages and instrumentation C3 through C6. Since then, she's had symptoms, she's had loss of range of motion, she's had some discomfort following the surgery. This is her pre-injury x-ray. I mean, that's a big surgery. Typically, when you have a spinal injury, the top part of the head, C1, and C2, is where most of your motion is. Sorry, I went backwards. Is where most of your motion is. When you're doing a fusion down here in the lower part of the cervical spine, you very rarely will lose a lot of motion. But once you start getting up here, there will be some motion loss. So this patient had motion loss, always had some discomfort, and always had some symptoms. She came to me, and you can see right here where the big spur is. This is a long-standing spur with a disc osteophyte complex and complete narrowing, loss of disc material there. And that's a clear pre-existing condition. This is your bumper, catastrophic event, $600 worth of damage. I don't know how it didn't kill her. Just kidding. It's, I mean, this is a very minor incident, $600 worth of damage, but the eggshell patient, it set her off. She has, following the surgery, left-sided neck pain, headaches, loss of strength in the left hand, difficulty sleeping due to the pain. All new symptoms. Documentation is vitally important. Documentation, documentation, documentation. This is what I put in my future medical care plan for her. Due to her ongoing complaints, you can read this. Due to ongoing complaints, correlate with diagnostic studies and the neurologic deficits, and within a reasonable degree of medical probability, she will need a cervical decompression instrumented fusion. However, due to the previous fusion at C3-6, she would need not only the hardware removal and exploration of that fusion, or she would need that in addition to the extension to the C6, C7 level. I addressed it. I hit it head on. I addressed that it was right there. No one's going to doubt that that wasn't part of the problem. I addressed the global cost for a complicated multi-level revision decompression like that. I documented future needs besides the surgical intervention, repeat injections, cervical local or parenteral injections, including, as Dr. Badai said, PRPs, stem cells, chiropractic care, physical therapy, acupuncture, anything that could be reasonable. Medical bills totaled about $50,000 for all the treatments she'd received, multiple epidurals, chiropractic, physical therapy, diagnostic studies. This was just recently settled. The claim was paid at the time of demand for the policy limits of $250,000. They didn't ask for any prior medicals. They didn't ask for any extensions. It was all about the documentation. And the reason I'm showing this, I just got this literally, before I finished my talk, I had just gotten this from one of the attorneys that sent this to me to find to show me what their client was able to receive out of this injury. And I wanted to share that if you document it correctly, these things can be a lot easier for your clients. That's me because of what I did, and that's me. So I want to thank you all for the having me here. I appreciate you choosing me to be one of your panelists.
Thank you so much, Dr. Korish. And of course, we have a little bit more time left, so we wanted to open up for forum discussion. Anyone who might have any questions for our lovely attorneys or doctors, we invite you to do that now. And also, afterwards, if you want any of the presentation materials discussed today, you will be able to access that if you email me at events.dm, D as in Dan, M as in Mark, at injuryinstitute.com. And I can send you over all the doctor information, all the attorney information of your choosing. So we invite anyone who might have a question to submit that to us now, or if we don't get you in time, to email as well, so we can get that for you. Michael Zeiger asked, are there any of the providers present taking denied work comp claims?
No.
Not currently. Okay.
Not a thing anymore.
Yeah.
Okay.
I mean, no, I don't, not workers' comp at all. I mean, personal injury, PPO, Medicare, cash, but not workers' comp.
Okay, great. All right. Well, I think that will about do it unless we have any other questions. Of course, if we don't get to you, you can, of course, email. So I want to thank all of our panelists for being with us today. I really appreciate it. And signing off from Injury Institute, thank you for coming by. Have a great day. Take care.
Thanks to all the doctors.
Thanks, guys.
so much. And go Dodgers.
Yeah.
Go Dodgers.